All right, in this explainer, we are diving right into some of the most powerful bedside tests you can do for a dizzy patient. We're talking about the HINTS exam and some key positional maneuvers. These are the tools that can help you tell the difference between a benign, inner ear issue and a life-threatening stroke right there at the bedside.
So let's just jump in with one of the most counterintuitive but absolutely critical principles in all of vestibular medicine. Why on earth is a normal test result in a patient who is spinning out of control a major red flag? Well, the answer really gets to the heart of what this test is actually measuring.
And here's why it matters so much. Because a correctly performed HINTS exam is actually more sensitive than an early MRI when it comes to spotting a posterior circulation stroke. I mean, the original research on this is just stunning. For patients in acute vestibular syndrome, HINTS has a sensitivity of 100% for stroke. You compare that to about 80% for an early MRI, and, well, that is a statistic that should absolutely change your practice.
Okay, so let's break down this powerful three-step sequence. Now remember, HINTS is specifically for patients who present with what we call acute vestibular syndrome, or AVS. That just means they've got continuous vertigo, some nystagmus, and they're unsteady on their feet. So, HINTS is our acronym. It stands for head impulse, nystagmus, and test of skew. Let's take a look at how these three really quick bedside tests come together to give us such an incredibly powerful diagnostic picture. The first step, the head impulse, is a direct check on the vestibulo-ocular reflex. We call it the VOR. You know, that's the reflex that lets you keep your eyes locked on a target even when you're moving your head. Our goal here is super simple. We just want to see if that reflex is working or if it's broken. And this right here perfectly illustrates that crucial counterintuitive point. In a patient with AVS, an abnormal test, where you see that little ketchup saccade, is actually reassuring. It tells us the peripheral system is offline, which is exactly what we'd expect in something like vestibular neuritis. But a normal test where the eyes stay perfectly locked on target means the VOR is intact. And if the VOR is working just fine, then something else, something central has to be causing that severe vertigo. And that is the red flag. Next up, nystagmus. A peripheral pattern is pretty predictable. It's usually horizontal, it only beats in one direction, and it gets stronger when the patient looks toward that fast phase. A central pattern, though, that's what we worry about. You gotta look for a nystagmus that changes direction depending on where they're looking, or if it's purely vertical or torsional. Any of those patterns point toward a central cause. And the final step in HINTS is the test of skew. This is just a simple alternate cover test. You cover one eye, then quickly switch to the other, and you're looking for any vertical correction when an eye is uncovered. Any vertical movement you see is called a skew deviation, and it's a really clear localizing sign of a brainstem lesion.
Now here's the really crucial part. You don't need all three of these findings to be worried. Just one of them is enough to point to a central cause. The mnemonic infarct is a great way to remember it. Impulse normal, fast phase alternating nystagmus, or a refixation on the cover test, which is our skew deviation.
Okay, let's build on that with something called HINTS Plus. And while we're at it, let's cover the single most important rule for using this test safely and effectively. So, we get to HINTS Plus by adding one simple thing, a bedside hearing screen. A finger rub test is usually enough. Now, why is this so critical? Because a stroke in the anterior inferior cerebellar artery, or AICA, can cause both vertigo and hearing loss, which perfectly mimics labyrinthitis. In that case, the HINTS exam might actually look reassuringly peripheral. That's why any new, one-sided hearing loss in a patient with AVS is a huge red flag that needs urgent imaging.
Now, for the absolute non-negotiable rule for HINTS. It is only valid in patients who are actively experiencing continuous vertigo and have nystagmus at the very moment you're examining them. If you try to use HINTS on someone with episodic vertigo or after their symptoms have gone away, the test is totally invalid. And worse, it can give you some dangerously false reassurance. Okay, time to shift gears. We're moving away from patients with continuous vertigo and focusing on those with triggered episodic vertigo. And for that, the very first test we reach for is the Dix-Hallpike. It's the gold standard for diagnosing the most common cause of vertigo out there, posterior canal BPPV.
The technique itself is a really precise four-step sequence. You'll start with the patient sitting up, turn their head 45 degrees to the side you want to test, and then, in one smooth, quick motion, bring them down to a lying position with their head extended about 20 degrees. Now the final step is the most critical. You have to hold this position and carefully watch their eyes.
So what are we looking for? Well, the classic signature for posterior canal BPV is very, very specific. It's an upbeat and torsional nystagmus that has a short delay before it starts, it lasts less than a minute, and it gets tired. It fatigues, meaning it lessens if you repeat the test. Any other weird patterns, like a persistent, pure downbeating nystagmus, should immediately make you think about a central cause.
You know, the single biggest mistake clinicians make with this test is stopping way too soon. The patient's going to feel dizzy, for sure, but the nystagmus, that's the objective sign we need to see, can have a delay of 5, sometimes even 10 seconds. You have to fight that urge to sit them back up. You've got to hold a position for at least 30 seconds and ideally 60 if you want to avoid a false negative test.
So what do you do when the patient's story sounds exactly like BPPV? You know, they get these short bursts of vertigo when they roll over in bed, but the classic test comes up negative. Do you just stop there?
No way! You perform the supine roll test. This maneuver is designed specifically to find the second most common variant, lateral canal BPPV, which, by the way, the Dix-Hallpike will often miss completely.
So with the patient lying flat, you just roll their head quickly to each side. If you see a horizontal nystagmus, that confirms lateral canal involvement. Then you just need to watch its direction. Does it be towards the ground, which we call geotropic, or towards the ceiling, apogeotropic? This difference is key because it tells you if the debris is free-floating or stuck, and it helps you pinpoint which ear is the problem so you can do the right treatment.
Okay, I know that was a lot of technical details, so let's just boil it all down to the most critical, practice-changing points that you absolutely need to remember.
Look, if you take absolutely nothing else away from this, please remember these 4 things. 1. HINTS is only for patients who are in active acute vestibular syndrome. 2. The head impulse test is totally counterintuitive. Abnormal is reassuring while normal is dangerous. 3. A central HINTS pattern is better than an early MRI for diagnosing a stroke. And 4. Don't you dare cut the Dix-Hallpike short. Hold that position for at least 30 seconds.
In our final explainer in this series, we're going to synthesize all of these different pieces. We'll bring in orthostatic vital signs and a targeted neurologic exam to really build out a complete defensible clinical framework for any dizzy patient that walks through your door.
And that really leaves us with a final thought. Mastering these skills at the bedside isn't just some academic exercise. For the dizzy patient, a confident and correctly performed examination doesn't just make you a better clinician, it can literally be life-saving. Thanks so much for joining this explainer.